And Wyatt, I'll have you take it away.
Hi guys, I'm Wyatt. I'm a fourth year at Ross, and sorry if you can hear any sirens. I do live close to the hospital, so apologies for that. Um, but I am going to be applying EM, and so I just wanted to talk to you guys a little bit about the number one chief complaint coming into the ED, which is acute abdominal pain. And I'm going to be specifically talking about adults, so not peds in this case, but so, just to give you guys a quick overview of kind of where we're going, I just wanted to start with talking about why abdominal pain really matters in the ED setting, and then apply that to a hypothetical standardized patient scenario. And then from there, kind of working through a quadrant-based approach, talking about how algorithms and tools can help us make decisions as clinicians or physicians in the ED setting, and also talking about where those tools don't always get it right and can't be used as a standalone process. And then coming back to our standardized patient and then kind of just wrapping up after that with some discussion. So, this is our hypothetical patient scenario. Mr. Clark, he's a 58-year-old man with well controlled hypertension. He presents with 3 days of progressively worsening left lower quadrant pain. And the pain started gradually, but then became constant and is associated with some fevers and constipation. But he denies any GI bleeding, vomiting, or any urinary symptoms. So on exam, he's febrile but hemodynamically stable. He has focal left lower quadrant tenderness with some mild voluntary guarding, but no peritoneal signs. On labs, he does have an elevated white blood cell count, and our initial bedside ultrasound here was negative. So from there, we'd want to proceed to CT imaging, which is really key to narrowing our diagnosis in the ED setting. And that's kind of where I'll leave it for now, and then we'll come back to him at the end. So I just put together this diagram, as I'm sure we all do in our minds when we're looking at a list of differential diagnoses. But with Mr. Clark's presentation, things like diverticulitis, the entire spectrum of colitis, all of the different subtypes would come to mind. Of course, any malignancy as well. Some renal involvement could be there on our list. Pancreatitis, a little bit of the wrong area, but still something to put on our list, as well as even peptic ulcer disease or some sort of gastroenteritis, SBO. An atypical presentation of appendicitis would be important to rule out. And then I just put that little box of our kind of can't miss or red flag kind of diagnoses of wanting to rule out any SBO, AAA. Ischemic colitis would be important to rule out, as well as those atypical presentations of appendicitis. So, as I mentioned, abdominal pain is the most common reason adults come to the ED, but upwards of 25% of them are discharged with undifferentiated abdominal pain. And so, really, despite how often we do see it, it's not really always straightforward in terms of arriving at a diagnosis. And so, a lot of patients really leave without that clear diagnosis. And so, I think that's really because the presentations of acute abdominal pain can be not only generalized, but completely benign to life threatening. So there's a huge range of different disease processes and how they can range in terms of presentation. And so I think that's why having like a structured quadrant based, going by quadrant or area, region approach is really helpful. And it lets us risk stratify really quickly and then keep our patients safe while doing so. So, starting in the left upper quadrant, I thought we'd start there. Um, this is where we commonly think about processes like peptic ulcer disease or gastritis, any upper GI bleeding, pancreatitis as well, any splenic pathology, which might come from trauma, which would be a little bit different, but still something we'd want to consider. And then even referred or any cardio or referred cardiopulmonary diseases as well. And so, from a clinical standpoint, we'd really want to evaluate for those features of upper GI pathology like hematemesis, any hemodynamic instability, syncope, anemia shown on labs, or things like elevated BUN, creatinine, and liver values as well. So this is where our first algorithm or scoring tool can come into play, which is the Glasgow-Blatchford score. And it's scored from 0 to 23. So I just took a screenshot of one of the images of it and just filled in the information. But obviously you could fill this out pretty quickly in the ED setting. And essentially, scoring a 0 to 1 would be low risk patients who wouldn't require admission or any urgent endoscopy, and then would be managed more outpatient with follow up, good follow up, which is another importance of outpatient follow up as well. And then scoring a 2 or greater is going to suggest a increased risk of some sort of clinically significant upper GI bleeding and the need for admission for at least observation and possible endoscopy from there. Scores greater than 6 are going to indicate greater severity, increasing the probability of needing either a blood transfusion, an endoscopy, or even surgical consult and surgery. And so essentially, a higher score is correlated with a higher likelihood of needing some sort of inpatient hospital intervention. So this can really help us in the ED setting about knowing kind of where to put patients or where their time in the ED is going to go, whether they're going to go home or possibly need to be admitted. So, moving to the right upper quadrant, this is where our biliary pathology becomes a major cause of acute abdominal pain in the ED. So, I know we've all seen on surgery the numerous cholecystitis, gallbladder cases, but we do always want to think about and consider cholecystitis, choledocho, cholangitis, along with including hepatic disease and pancreatitis as well. And so clinically, when we think about right upper quadrant pain, we want to look at our any signs for systemic infection, get focused labs from there with maybe LFTs, definitely white blood cell count. And then we also would like to use the bedside because it's quick, easy, painless, and gets results very quickly. A bedside right upper quadrant ultrasound to evaluate for possible biliary pathology. And so this is where the Tokyo guidelines, which are not exactly a scoring system, but they are a guideline to be used to distinguish between uncomplicated biliary disease in acute cholecystitis versus cholangitis. So differentiating between totally uncomplicated biliary pathology and then more of acute intervention needing acute cholecystitis versus cholangitis. So you can see here there are two Tokyo guidelines because there's one for acute cholangitis and then one for acute cholecystitis. Sorry, the table one is a little bit small, but there's a lot more that goes into acute cholangitis, obviously, because it is more severe. So essentially, they're helpful in the ED because they help us move beyond just our clinical knowledge, which of course is important, but also these guidelines really help us guide both diagnosis as well as severity based management. And so the Tokyo guidelines for cholangitis and cholecystitis have three categories, so A, B, C. And so for suspected cholangitis, you need one criterion from category A plus one from either B or C. And then for suspected acute cholecystitis, we need one criterion from A and then one from B. And then for a definitive diagnosis of either of those conditions, we need all three categories, A, B, and C, to be met by criteria. So you can see on the cholangitis, it's a little bit more specific with systemic infection signs and different lab values versus our acute cholecystitis Tokyo guidelines are a little bit more based on like imaging and then just some labs from there as well as physical exam. So in the right lower quadrant, we normally think of appendicitis. It's normally at the top of our mind and the top of our differential diagnoses list. But I think we still need to consider other causes like gastroenteritis, any renal colic, or even SBO as well. So our approach here would start with correlating the right lower quadrant pain with inflammatory signs and then objective findings on our exam and labs as well. And so from there, we can use tools like the Alvarado and the AIR score to help us risk stratify those patients and decide who would need imaging, who would need observation, or even a surgical consult from there. So both the Alvarado and the AIR scores combine symptoms and exam findings and labs to help us stratify that appendicitis risk for that specific patient. So you can see on the left-hand side, it's the Alvarado score. I'm sure we've probably used both of these at some point in our rotations, but for the Alvarado score, scoring a 1 to 4 is going to be or indicate a low probability of appendicitis, which is around 20 to 30% from what I was seeing. And so normally those patients are safe for discharge with return precautions and then outpatient follow up as well. Scoring a 5 to 6 is going to be more of an intermediate probability. And those patients are usually admitted for observation with serial exams and further labs and further imaging, possibly. Scoring a 7 to 10 is a high probability of having acute appendicitis. It is around 90%. And from there, those patients are obviously admitted not only for observation, but also for management. And then surgical consult is recommended for the likelihood of appendicitis in this case. And then using the AIR score, which is on the right, there are 7 variables that are assessed and scored accordingly. So on the AIR score, a score of 0 to 3 is going to be our low probability. 4 to 8 is going to be our intermediate, and then 9 to 12 would be our high probability. So essentially, low AIR scores support more of that outpatient management versus our intermediate scores would be observation, admission for observation, and further labs and imaging. And then the high scores would prompt our early surgical consult. And the kind of main difference with the AIR score is that it does include CRP. There you can see it at the bottom. And so the Alvarado score just has the left shift and the leukocytosis as well, but they do include the CRP on AIR as well. So when we move to the left lower quadrant, I think diverticulitis becomes one of the most common and important diagnoses to consider. So unlike appendicitis or upper GI bleeding, there isn't a validated ED scoring system that we really use to diagnose diverticulitis. So I think it really highlights the limits of just relying on these tools alone and not using anything else, not using our clinical knowledge with the tool, but just using the tool and plugging in numbers either on your phone or on the computer at the hospital. And so diagnosis here really relies on clinical assessment, again, getting labs, but most importantly, our CT imaging. And so CT not only confirms our diagnosis, but it helps distinguish between uncomplicated and complicated diverticulitis, which would in turn further help us decide whether we want to manage that patient more conservatively or for complicated diverticulitis, which would include things like an abscess, possibly a perforation, a fistula, or some sort of obstruction. We definitely would manage those patients differently than someone with uncomplicated diverticulitis. So for left lower quadrant pain, our decisions here are really driven by the disease severity and complications rather than a score itself. So I think it reinforces the need for our thoughtful clinical reasoning, creating a good differential diagnoses list, and then narrowing down from there instead of just using a scoring system. So I wanted to talk a little bit about epigastric pain. It's not one of our 4 quadrants, but it is on our extended quadrant, abdominal quadrant image that we all know and love from the textbooks. But acute pancreatitis is one of the key diagnoses we do worry about when treating these patients or seeing a patient with acute epigastric pain coming into the ED, because the clinical course for appendicitis can range from pretty benign to very severe and life threatening. So, after confirming our diagnosis based on our clinical presentation, our bedside imaging, perhaps, and looking at labs like a lipase, which is really important. We would then want to switch and shift over to our risk stratification. So that's kind of where the BISAP score is ideal for the ED because it uses our early bedside data and looks at BUN, any altered mental status. It looks at SIRS, age, race, and then evidence of pleural effusion. And it predicts mortality and severity of disease. So when you look at the BISAP score, scoring 0 to 2 is classified as lower mortality at around less than 2%. And then a score of 3 to 5 is associated with a higher mortality rate. And although Ranson's criteria, which is still used and I've used before, I'm sure we all have, but it is, of course, well established, but it does require 48 hours of inpatient data, which does limit its use in the ED. So I think specifically talking about the ED setting, we don't use Ranson's criteria in terms of that because the BISAP score provides early actionable risk stratification at the point of care. So when we consider flank pain in the ED, renal colic due to uretolithiasis is common, but we also want to have on our differential maybe a cause of infection, systemic infection, any vascular pathology, and then obviously want to narrow down or rule out those high risk red flag diagnoses. And so we want to assess classic features like sudden onset pain, pain with radiation, any hematuria, nausea, while of course ruling out the infection, systemic infection, or any obstruction. And so this is where the Stone score can come into play. So it's a validated tool that helps us stratify the probability of someone having uretolithiasis using key clinical variables. So you can see it there, hopefully. But essentially, it takes sex of the patient, duration of pain. It does have race in there, nausea, vomiting, and hematuria, whether it's present or absent on dipstick. So scoring a 0 to 5 would be our low probability of uretolithiasis. So it's going to support starting with ultrasound and then outpatient follow-up. And then scoring 6 to 9 is moderate probability. And normally here is where CT imaging is recommended, but that patient probably would not be admitted and we would follow up outpatient, or that patient would follow up outpatient. While scoring 10 to 13 would indicate more of a high probability and generally warrant CT imaging and possible admission depending on the other factors with that patient specifically. And so I didn't, this isn't a quadrant, obviously, but I did want to talk a little bit about non localized pain as well as recurrent abdominal pain, or people that come in multiple times with generalized abdominal pain. So our initial focus here would be ruling out, again, those can't miss diagnoses, which can present before our pain might localize, such as like early appendicitis, SBO, mesenteric ischemia, or any aortic pathology. And so we'd want to start by, of course, assessing hemodynamic stability and then using our physical exam and labs to look for any signs of occult high risk disease. And then, of course, keeping a broad differential early on. So, more common inflammatory causes like maybe colitis, gastritis, or an irritable bowel disease flare are typically considered after those high risk pathologies are excluded, since these are often declare themselves over time. And so we do want to consider those. We definitely don't want to not consider them, but we do start with our high risk pathology. So in this setting, CT abdomen with IV contrast is normally our initial imaging modality. For patients with recurrent low risk presentation, our GRACE score, which I think you can hopefully see, it's a little small. I couldn't blow it up bigger, but the GRACE score can help us guide imaging decisions while, of course, minimizing those repeat unnecessary CTs. Because if we have someone come in multiple times with this recurrent abdominal pain, we don't want to be scanning them and setting them through a CT machine every single time. So you can kind of see there, but it essentially gives you questions to ask and then recommendations from there as far as the GRACE score goes. And then it also details on the top in the green section what it means to be a low risk person with recurrent abdominal pain. So I think it's really helpful, and I've seen it on posters in our hospital, but it's everywhere. So it's definitely easy to find, which is good. So this table just pulls together the major tools and algorithms that we talked about. And I just wanted to kind of put it all together so it would be easier for everyone to see because I know there's a lot and a lot of numbers being thrown at you. So essentially, each of the algorithms is really just designed to answer a specific clinical question based on pain location. So, like we talked about with the Glasgow Blatchford score, it isn't diagnostic. So, it just helps us identify who can be safely discharged versus who needs admission. And in the Tokyo guidelines, we just combine clinical findings in our labs to diagnose acute cholecystitis or cholangitis and then grade its severity, which would in turn directly guide our management of that specific patient. So for right lower quadrant, we talked about the Alvarado and the AIR scores, and they estimate the likelihood of someone having appendicitis or acute appendicitis, and then help us decide between observation, imaging, or surgical consult, particularly in those classic presentations. So that is one of the limitations of it, is it's not great for atypical presentation of appendicitis, which obviously occurs. And then tools like the BISAP, Stone, and Grace 2 scoring system are going to support early risk stratification or imaging decisions, but none of those are to be used standalone and they can't replace our clinical judgment. And so they're really most effective when they're used specifically for their intended clinical context. So I just made this little diagram to talk about the limitations. And so essentially, they're not perfect. A lot of them do have flaws, and a lot of them have been repeatedly re-updated through case studies and different research going on, which I think is great because we're always learning and wanting to be better and make the scoring systems better, make these tools better. And so, like we talked about, the Glasgow Blatchford score just helps us decide for someone with upper GI bleeding who can be safely discharged, but it doesn't tell us any source of it. And so when you're looking at things like the Alvarado score, it actually has reduced accuracy in women, any atypical presentation, and in the elderly as well. And so, like the BISAP score really just predicts our severity. It doesn't diagnose pancreatitis at all. And then the Stone score is interesting because it has limited accuracy, of course, when used alone. But there was actually a recent study that said it was completely inaccurate to be used to tell a physician or tell yourself whether it would be important to get a CT on that patient. So it's not a tool that we can say, oh, check, they scored on the Stone score, send them to CT. So it's not actually very good for that at all. And then, of course, our GRACE score really only applies to our recurrent frequent flyer, for lack of a better word, low risk abdominal pain patients. So it's not going to apply to any first time or unstable patients, which is difficult because I think we all see people who come in, whether in outpatient or in the ED setting, that say, I think I might have had this before. I'm not sure. It kind of feels the same. And so it's difficult to know kind of when to use that because it really is only good for people with low risk recurrent abdominal pain. So I just wanted to revisit Mr. Clark, our patient again, and just kind of put him through all of these guidelines. So we could consider right upper quadrant biliary disease, but when I scored him on the Tokyo guidelines algorithm, he didn't meet any of the criteria. For appendicitis in our right lower quadrant, our Alvarado score was 1, so very low risk, and he was low on the AIR score. Scored a 0 on the Glasgow Blatchford score. And then, as far as identifying flank pain or any renal colic issues, he was a score of 2, so very low probability. And then moving to our left lower quadrant, again, no validated scoring system or tool here. And so when we did our CT with contrast of his abdomen pelvis, we did arrive at that final diagnosis of acute, uncomplicated diverticulitis. So just to wrap up, I know I threw a lot of numbers and pictures and scoring things at you guys. But I think a quadrant-based framework really just gives us a structured and efficient way to approach abdominal pain in the ED because we do see it a lot, and we will continue to. Um, but these validated scoring systems, they are incredibly helpful for our risk stratification and efficiency, guiding imaging, how we're going to manage. But only when they're really applied in the correct clinical context. And ultimately, they cannot be used alone. And they're not just, AI has not taken over yet. So we can't just plug in things to the MedCalc app for specific scoring systems and then just go from there, right? We want to do that, but we also want to, of course, use our clinical judgment, use our clinical knowledge that we have, and always treat our patient, not just plugging in things to a scoring system and then diagnosing from there. So that's it. Thank you guys for letting me talk your ear off. So yeah, just let me know if you have any questions. I really appreciate it. And yeah, hope everyone has a good year. Happy New Year. Happy holidays.
Yes, Elijah.
Okay, I wanted to ask, you mentioned how some of the scoring systems were had some inaccuracies to them or were not as efficacious in particular situations. I wanted to find out, do you know if there's been any studies that have shown the combination of scores to increase the accuracy, or does that not work? Or even if there's been an increase in accuracy with like using them in tandem. Specifically, I'm kind of thinking more like the right upper quadrant pain with the Alvarado and the AIR score, being that they're evaluating some of the similar things. Yeah, have you seen, people using them in combination increase the accuracy, or using AIR then Alvarado or Alvarado then AIR and seeing a different, result or score there?
Yeah. So yeah, that's a great question, but also good to look at the right upper quadrant pain. I have seen them be used together. I actually saw on surgery and IM, some physicians prefer one versus the other and don't even look at the other one. So, but then some will use both together. So those have been used together, and I have seen a couple case reports and studies of using both of them together. As far as the other ones and using them in tandem, there's not a lot of reports out there of these studies being used together. I do know the Tokyo guidelines, they have been re-updated many, many times over the years, which is great. And so I think we need to keep re-updating them as our patient population changes or things like that, or seeing new presentations of those diseases. And so the only ones that I really know that we use in tandem are going to be that right upper quadrant. And it does increase the accuracy of them. It can guide us with our kind of being sure of what we're looking at in terms of differential diagnosis and kind of arriving at that when we use them in tandem. And there have been some studies that specifically for the AIR score that has CRP on it, that not everyone's going to have an elevated CRP. It's more of a vague, generalized lab to do. So some people use the AIR and Alvarado in tandem so that we can kind of not have to only rely on the reason that they scored on the AIR score was high was because of the CRP, or they are presenting like they would score high from our clinical context, but then they don't have an elevated CRP, so they don't gain a point from that. So those two we definitely do use in tandem.
Okay, thank you.
Anyone else have any other burning questions? Okay, well, thank you so much, Wyatt, for your time and all the preparation you had for today, too. I really appreciate it. I know everyone else does, too.
No worries. Thank you guys. I appreciate it.